Hello everyone, and welcome to Exploring Advanced Alternative Payment Model Opportunities, a webinar sponsored by Cardinal Health Specialty Solutions. Today, we'll review advanced alternative payment models and their role in CMS's quality payment program. This webinar is the conclusion of our three-part MACRA webinar series. If you missed our previous webinars, visit our new MACRA Resource Center at cardinalhealth.com/MACRA. Our Resource Center also includes in-depth articles on MACRA and other resources to expand your knowledge and prepare your practice. Just a few notes before we begin. Please note that the conference line will be muted to reduce noise. To submit questions, use the chat feature in the lower left-hand corner of your screen. A recording and a copy of today's slides will be emailed to you after the event. And now let's meet today's hosts. Bruce Feinberg, Vice President and Chief Medical Officer from Cardinal Health Specialty Solutions. A nationally recognized expert in oncology, Dr. Feinberg established and led one of the first and largest integrated oncology practices in the southeastern U.S., is a best-selling author and regularly published in peer-reviewed journals. Next, we have Martie Ross. Martie is a MACRA expert and consultant from Pershing Yoakley Associates and has 2 decades of experience as a healthcare transactional and regulatory attorney. Martie serves as an advisor to healthcare providers navigating today's complex healthcare landscape. Please welcome today's host. And now Dr. Feinberg will get us started. Dr. Feinberg?
Hi, everyone. Pleasure to be back with you. In our first webinar, we introduced the concepts of value-based care, looked back at its origins through PQRS and meaningful use and reporting. In the second webinar, we introduced MACRA and MIPS. And in this, the third webinar, we're going to be digging in deeper into alternative payment models. Now, on the alternative models, as you'll see, the goal that the government has and likely payers will follow is for everyone to move into these models. So this is not a possible future scenario. This appears to be the future scenario. And Martie's going to kick it off, and she's going to begin by addressing the historical basis for this difference between fee-for-service-based reimbursement versus value-based care. Martie, take it away.
Great. Thanks, Dr. Feinberg, and welcome, everyone, and thank you for joining us. If we're to discuss alternative payment models, I really want to take a step back first and help everyone appreciate just how challenging this transition from fee-for-service reimbursement to value-based reimbursement is going to be, because it will outline for you the hard work ahead, but also hopefully help you appreciate how critical this transition is. In fact, fundamental this transition is if we're going to work to achieve that quadruple aim, that idea of improving the patient experience of care, achieving better outcomes, providing care more efficiently and reducing costs, and importantly, making the experience more rewarding for providers within the system. So let's start with sort of the key factors of what we know of a fee-for-service reimbursement model. This is, or sometimes we refer to it as per-click reimbursement. The idea here is that you provide a service and you receive a set payment amount for that service. Now, the incentive that creates is for a provider, regardless of type, to maximize the number of patients for whom they provide services, and then for each patient, maximize the number of services provided. That's the pure economic motivation. So stripping away from that any other type of consideration, that's what the payment model does. That's the pressure it places on providers. Now, how are we going to evaluate the amount of payment to be received? How do we describe the value of the services? And in a fee-for-service reimbursement model, we do that through code sets. In the hospital setting, we have DRGs and APCs. In the physician setting, it's generally by CPT, so that we describe the service we're providing by these code sets which then match up with the fee schedule and tell us the amount of payment to be received for that effort. Now, how do we regulate fee-for-service reimbursement? How do we prevent it from spinning out of control and payment being sought for services that are not rendered? Well, there we have the complicated network of fraud and abuse laws that are intended to prevent improper referrals or improper financial relationships that potentially could cloud providers' judgment with respect to appropriate services. We also then just have masses of reimbursement rules, this concept of medical necessity of when it's appropriate to provide a particular service. So we have those regulators running to keep in check the incentives that are created by the fee-for-service reimbursement models. This model then really places providers in silos that each works individually as opposed to being part of a care continuum, and each meets the patient individually as opposed to seeing the broader care provided for that patient. And unfortunately, it also forces providers into being competitors. So rather than necessarily working together, they see each other as chasing the same economic gain, and thus are competitors. Patients within this system then really often are uninvolved in their care, that there is no incentive for the provider to provide patient education, to engage the patient in decision making. And thus we often have patients that end up with unmanaged chronic conditions because they're not taking care of themselves or enabled to even accomplish that. In fact, the old joke is the perfect patient in a fee-for-service reimbursement model is one who has multiple chronic conditions and yet refuses to die because they are an opportunity for repetitive services. Finally, let's consider that concept of risk. With a fee-for-service reimbursement model, that risk resides with the payer. The payer has to somehow account for the fact that more and more services are being provided for a population, and thus the cost to provide those services, to ensure those services, is going to go up. As a result, we end up with a system with increasing costs. As you know, healthcare is now targeted to be nearly 20% of our gross domestic product within a number of years. And it's in part because of the incentive structure that fee-for-service reimbursement reinforces. Now, let's go to the completely other side of the equation and talk about a value-based reimbursement model and compare how this works within those same 6 factors. So what are the incentives in this model? If you are paid for delivering value, if you're paid for keeping a population as healthy as possible and receiving appropriate services, right place, right time, right services, what are your incentives? Then you're part of a care continuum, and you're going to work to manage that patient population. So you're going to be very aware of the risk that's in that population in terms of diagnosed conditions and potential for development of complications. And as the interest then is to coordinate services provided. So we want to ensure that there aren't duplicative services or that we're running an inappropriate test for a particular patient. The measures we have then of value, so how we determine the proper payment to providers, are really going to be measures of quality and efficiency. So can we compare the services furnished by providers, so the care they provide to a patient population? We want to look at quality measures as well as efficiency measures. The manner in which we regulate providers and thus the dollar spent in the system really falls to network participation. That if you have a continuum of care, a network of providers who are receiving a payment to manage a particular patient population, the providers who are part of that network are really going to be regulated by the network. It's the network that's going to be evaluating that care they provide, the network that's focused on the efficiency in delivering care. And so you find yourself pulling away from those complicated regulatory structures of the fraud and abuse laws and reimbursement rules, because it's really within the network how providers are self-regulating. Providers then, of course, then come out of their silos and are then part of a continuum of care. is that one cannot stand alone in a value-based reimbursement system. That you do have to have this connectivity to continuum and networks. Now that's not to say that everyone becomes part of a single tax identification number and there's one overarching organization orchestrating this process. No, in fact, it isn't the economic ties that are critical. It's really the clinical integration that is driving these relationships and bringing collaborative relationships among providers. Patients then will, in a value-based reimbursement system, be more educated as to their health and more engaged in their care and how they manage their own conditions. Of course, the last element here is where does risk go in a value-based system? And here it migrates from the payer to the providers. The payer simply determines an amount that's appropriate for the network to provide care for a particular population. It's then to the providers to ensure that care is provided within that budget that's assigned. Now here is where most concern lies with regard to value-based reimbursement. But if you go directly from a fee-for-service model and then only look at where the risk lies in a value-based system, that is a reason for concern. But appreciate that there's a great deal that has to change in this system and a realignment in the system before providers are in a position to manage risk. And so as we talk about alternative payment models, we're going to talk about the evolution towards provider risk, not a revolution where providers find themselves one day holding all the risk without the tools to accomplish that.
Martie, that was great, a great bit of insight and introduction to today's topic. And I think for those who are on the call, and especially physicians who find this all very insulting to think that we're nothing more than economic animals and do what's in our own best interest as opposed to the patient's best interest, you have to understand that from a macroeconomic perspective, the data is not necessarily on our side. To take an example, the rates of C-section vary amongst communities in the nation, as low as 7%, as high as 70%. So 7 may be too low, 70 is clearly too high. There aren't a lot of ways to explain that degree of variance. And so what happens in a value-based system is whatever that appropriate rate is starts to be developed, and it becomes the point in which providers will migrate and payers will migrate in terms of what they will pay for and what they will support. Martie, I think there's also been a lot of hesitancy to embrace APMs with the notion that the current political environment is not going to be supportive of the model. It's a model that was, created during Obamacare, and as that is repealed and replaced, this is a piece of it that will go away, despite a Senate vote of 92-8 in favor of MACRA. How do you respond to that? The conversation around Obamacare and the Affordable Care Act is very confusing. And when politicians are talking about repealing Obamacare, they're really focused on what we refer to as the front half of that legislation, which was stabilizing or an attempt to stabilize the private insurance market plus reform the Medicaid program by expanding coverage. Those are where all the efforts are focused now, at least in Washington. Now, the back half of the Affordable Care Act was the genesis for a number of these programs. So it's there that you have CMS being authorized to create the Medicare Shared Savings Program. You have the creation of the Center for Medicare and Medicaid Innovation, which has been pushing many of these alternative payment models. But all of that is geared towards reducing costs of healthcare services. Not just the cost of insurance, but what insurance is buying. And if you can't control the costs of healthcare, if you can't change that incentive structure so that we're focused on delivering high value care and improving outcomes, we're never going to reverse that path. So indications out of administration officials thus far have all been consistent.
with this desire to continue this evolution towards alternative payment models. And if you consider statements made by Secretary Price and the new CMS administrator, all of those have been consistent with we have to work to reduce the costs of health care, not just the costs of health insurance. So it's a confusing political debate, but nothing has indicated that these programs are off the table and we are reverting back to straight fee-for-service reimbursement.
Thanks, Martie. And I guess with that, let's move on, and you can tell us exactly what is an APM.
Okay. Well, an APM is a pretty broad category, and there's been a lot of work around trying to get some language to explain these different concepts. And there is a learning action network that is CMS convened about 2 years ago that have really worked on simply defining the terminology we use around alternative payment models. And kind of building on their work, we think of alternative payment models as really 4 buckets. And they progress towards more of a comprehensive global budget, a true value-based reimbursement model. But there are certainly steps along the way. And as you take those steps, you're pulling further away from straight fee-for-service reimbursement and moving toward comprehensive global budgets. Now, oftentimes in this discussion of APMs, we'll hear folks that lived through the managed care wars of the 80s and 90s. And the criticism is that we're just going back and trying to relive the mistakes we made previously. And we're proving Einstein's theory that insanity is merely doing the same thing over again and expecting a different outcome. But the critical difference here, and I think there are 2 critical differences here, is that there is definitely an appreciation among policymakers as well as commercial participants in the healthcare market that this has to be an evolution, not a revolution. We can't wake up tomorrow and all of a sudden be at capitated payments, that we really have to move the system through a series of alternative payment models toward that end. And in fact, that end may not be the end. We may find that certain APMs that are less drastic than a global budget may be sufficient to change incentives and really realign the system in a manner that reduces costs while improving quality. But again, let's just go to these 4 buckets and talk very broadly, and then we'll give you some examples of what falls into each bucket. So we start on the far side with just fee-for-service payments where we live today, but we're starting to add some additional payments in the mix that are enabling providers to make this transition towards value-based reimbursement and population health management. And one of the first programs out there was Meaningful Use, where the government created an incentive structure for hospitals and providers to adopt electronic health records. So it's an enhancement to your fee-for-service payments outside of your fee-for-service payments that created an incentive to build critical infrastructure. Also, you've seen now fee-for-service, you've seen many payers, and particularly Medicare, moving towards care management payments. So previously under fee-for-service reimbursement, sort of the hallmark was you had to be eye-to-eye to the patient to have a billable service. And physicians rightfully complained that a great deal of the effort involved in managing a patient was done outside the 4 walls of the exam room or outside the 4 walls of the hospital, doing care coordination and outreach to the patient, and that was non-reimbursable. And in fact, because it wasn't paid for, we had very few formal care management programs. Well, now you know that CMS is moving towards paying for care management, and we'll talk about several programs now online that are built on care management payments. Moving one step over, we get to adjusted fee-for-service payments, and really this is where MIPS lives. This is saying that 2 providers furnish the same service but are very different in terms of the quality of care they provide and the efficiency of care they provide. So here's where we make adjustments to fee-for-service payments based on scores on different identified performance measures, and that's straight up what MIPS is doing, making fee schedule payment adjustments. Our third category is where we truly start getting into alternative payment models, but ones that are still built on a fee-for-service chassis. And so this is where a shared savings program lands or a retrospective episodic payment, and we'll talk in detail then. And then further over in the evolutionary cycle toward population-based APMs. So you're really pulling yourself out of the fee schedule and instead looking to pay for managing a population with an appreciation of the risk in that population, with an appreciation of the need to bring in new advancements in care, and making sure that appropriate providers are appropriately compensated. And so here we have concepts of sort of prospective episodic payment models, a direct primary care model where a primary care physician receives a certain budget to provide core primary care services for a particular population, so there's no any type of insurance billing going on in that type of arrangement. We have condition-specific global budgets. The program here that's in effect today is comprehensive care for patients with ESRD. CMS pays on a budgeted basis for those services. And then again, finally, as we've made reference to previously, comprehensive global budgets. So let's just drill down and talk about a few examples of these different categories. And let's start with this idea of care management services. Now, since 2013, CMS has added to the Medicare physician fee schedule fee-for-service payment for the services you see here on the screen, all of which involve some degree of non-face-to-face care management services with a Medicare beneficiary to different degrees. But all of these services are, and all of these, the reimbursement here is intended to fund the transition for providers. So that you need to develop this infrastructure of being able to provide care management services and to do data analytics work and the like. All of this is fee-for-service payments now available to finance those transitions. So if your practice has not yet explored this opportunity, it's certainly worth an investment of time. We've run a number of models for practices about the opportunity they have given their current Medicare population. If it makes sense for them to develop infrastructure up to provide care management programs, and it's been very few instances where it doesn't make economic sense to initiate a program like this. Also in the realm of paying for care management services, we have the CMS program Comprehensive Primary Care Plus. So this is, again, a pilot project that was initiated by the Center for Medicare and Medicaid Innovation, where there are 14 regions of the country where both CMS as a payer for the Medicare program as well as commercial payers have come together to incentivize primary care practices to develop up infrastructure for population health management. That primarily accomplished by paying a per beneficiary per month care management fee for an attributed population, and also providing a per beneficiary per month pay for performance fee to these practices to improve quality. So our initial round of CPC Plus is about 2,900 primary care practices across those 14 regions. Just last Friday, CMS announced the second round of CPC Plus, requesting applications from insurance companies that want to participate in the second round. But CPC Plus, kind of rather than being straight up fee-for-service care management services, we see these now being compensated on a per beneficiary per month payment. A program that's probably near and dear to some of our participants in today's call is the Oncology Care Model. And again, this was a program initiated by the Center for Medicare and Medicaid Innovation, focused on improving the management of patients who are going through chemotherapy. And practices had an opportunity to apply to participate in this model. Many were accepted into this program and are now operating under it. There are 190 participating practices across the nation. Just not Medicare here. You also have 16 participating commercial payers involved as well. The model's relatively straightforward, at least in explanation, maybe not in implementation, but a participating practice receives a $160 monthly enhanced oncology services payment for the period during which an individual is going through chemotherapy. So we start that period from the date chemo starts and continues for 6 months. They receive that payment to fund patient navigation activities, so even more engaged in the patient care than a care manager. A navigator is really intended to ensure the patient fully appreciates and is engaged in the different services that they're receiving. The development of a care plan for that patient and adherence to that care plan, and then also ensuring a patient has 24/7 access to clinical staff who can answer particular questions or address specific concerns. So that's this idea of, again, a care management type payment, here again offered on a PMPM basis, but at a heightened rate, appreciating that we've got a patient going through a particular episode of care who needs aggressive payment, who needs more aggressive navigation. Now also within the oncology care model, there is a second payment made to these practices, which is performance-based. And it's wrapped around an episodic payment for chemotherapy services. This is a retrospective episodic payment model, meaning that CMS has determined in advance a benchmark for a particular episode of care. And in this case, it's initiation of chemotherapy 6 months out. And it has established a range of benchmarks for different types of cancers and different therapeutic courses of treatment. CMS will measure the practice's financial performance against these benchmarks. And in the event that the practice is successful in reducing the cost of care within that episode as compared to the benchmark, there's an opportunity for a bonus payment to the practice. Now further out in OCM, so later years of OCM, this model becomes what we refer to as two-sided, meaning in the instance where the practice is not successful in reducing costs of care, and in fact the total cost of care for the episode is above the benchmark, then the practice is liable for repaying a portion of that amount back to CMS. So that's where risk is introduced. Now the offset for the practice accepting risk is that it becomes easier for the practice to earn the upside bonus payments if they are successful in reducing costs through enhanced efficiency. So here in the oncology care model, which is clearly an alternative payment model, we have different concepts of payment being brought to the table to create new incentives for providers. So we have the care management payment, but we've also brought in an APM that's based on a fee schedule model with this retrospective episodic payment for chemotherapy services. Now shifting over to another form of an APM built on a fee-for-service model, we have shared savings programs. And here the idea is the payer wants to create an incentive structure to reduce their total cost of care for an identified population. So here in the context of referring to total cost of care, that's the payer's total cost of what the payer has to pay out for services furnished for their insured population. So we create then an incentive where the payer is going to reward a provider network by paying them a portion of any shared savings. That shared savings is generated by reducing a total cost of care for that population. And of course we're going to have a regulator in this arrangement, which is the satisfactory performance on quality risk measures. Now we have these both one-sided and two-sided models. We have shared savings, so that if you, again, beat the benchmark, you share the savings. But if you exceed the benchmark, the provider network is going to have potential liability for repayment. Now, examples of these programs today include the Medicare Shared Savings Program, which is probably the most common and most familiar of any of the alternative payment models out there. We have over 550 accountable care organizations, just a provider network, that are participating today in the Medicare Shared Savings Program. Now, 95% of those ACOs are on a one-sided track, so they don't have downside risk, but they will progress towards two-sided models. We have a more sophisticated version of the MSSP program, which is called Next Generation ACOs. And again, this is a two-sided risk program with higher rewards to the provider network because they accept downside risk. We're also seeing a number of commercial payers moving towards these shared savings models. And in fact, in the commercial insurance world, it's a much easier product to manage because we simply base them off the medical loss ratio. And so the goal of that provider network is to help the insurer reduce their costs spent on care to a lower percentage of the premium dollar. So very straightforward program, and nearly all the major commercial insurers have a version of the shared savings model that are available in different markets to different types of provider networks. Finally, we want to talk here about episodic payments, because behind the Medicare Shared Savings Program, we now have these new episodic payment models that are really becoming more and more mainstream. So here we have a payer wants to look at a particular episode of care and figure out how to reduce their costs for a particular episode of care. So shared savings is all about total cost of care. But we appreciate that within a shared savings model, there are certain episodes that are just unavoidable. I mean, there are going to be people that need to have knee replacement surgery. There are going to be people that are going to have bypass surgery. So how does a payer incentivize a provider network to work together to reduce the cost of care within that episode and drive those costs down? And the idea behind episodic payment models is the payer says, I'm going to buy all the services within a particular episode of care for a discounted rate. And if you, network, are successful in actually providing that episode below that discounted rate, you keep everything. It's not a shared savings. You keep all of the revenue, all of the dollars generated in excess of the rate. Here, it's really the payer who calculates that predetermined amount for that episode. So certainly need provider involvement to check the validity of those numbers. And for episodic payment models, we have both a retrospective and a prospective model. Retrospective being we'll set the payment amount in advance, but we're going to allow all the providers to deliver services, be paid fee for service, and then at the end of the episode we'll have a true-up and figure out how much do we pay out versus what the target was. And the network then is either going to be responsible for any excess costs, or the network's going to receive the payment for having reduced the total costs of care. In a prospective model, you will have the network simply receiving a payment in advance for an episode of care. So if we know a patient's being scheduled for knee replacement surgery, the payer is just going to pay X amount to the network, and then it's up to the network to determine how it's going to pay out to each of the providers who are involved in that patient's care. Now, the examples of these programs today include the Bundled Payment for Care Improvement Program, which was again a pilot project sponsored by CMMI back in the early 2010s, 2010, 2011, when those programs rolled out. Those were voluntary initiatives. More recently, we have the episodic payment models. So these are the mandatory programs that CMMI has pursued, in that in specific metropolitan statistical areas, hospitals are finding themselves liable for the total cost of care around particular episodes. That we started with joint replacement. Now we have online a new program for both heart attacks and CABG. And the question there is whether those programs will actually go live. If you look again at Secretary Price in his confirmation hearings, was critical of what he referred to as mandatory alternative payment models. Specifically, it would be these episodic programs, these episodic payment models that CMMI has promulgated. So we are kind of in a holding pattern to see if these programs will actually go live. So that's a pretty broad overview of what's going on in the APM space by category, and then also drilling down on some specific programs.
Thanks, Marty. That was great. So I wanted to just use that prior example of cesarean section. So if you think about these episodes and these bundles, and if it was determined that the national average of C-section is 17%, then the payment determined that if you do 100 deliveries and 17 of them are C-section, and they on average double the cost for that individual, that gets weighed into that average that would be paid in the bundle or the episode to those provider institutions. And for that system, that community that has 7%, they're looking good. They're going to be coming out favorably. And that region community that was at 70% is going to have a lot of work to do, so they're not underwater. It's sometimes hard when you look at your individual practice to conceive of those things, but as one starts to think about these examples, and certainly in surgical, you can start to see there are some things that maybe we do that are fairly predictable in oncology and rheumatology, where you could start to see them placed into a bundle or an episode. I want to make sure everybody's aware. Again, you can ask questions online, so just type your questions in, and we'll be picking them up as we go. At this point, we still have a lot of content, so I'm going to pass it back to Martie, and she's going to discuss the role of APMs when in respect to improving quality.
Okay. Well, we started with a whole lot of background to get to this point, to how do we then consider alternative payment models in the context of the quality payment program. And we kind of have to go back to our very basic diagram of how these pieces fit together. So we know back in 2015, Congress passed the Medicare Access and CHIP Reauthorization Act of 2015, which we now refer to as MACRA. And the purpose of MACRA was to repeal the sustainable growth rate, the formula used to set the physician fee schedule rates, and replace it with a new model. That Congress directed CMS to create that program within specific confines that were defined in the legislation. And back in October of last year, CMS published its final regulations implementing what it refers to as the Quality Payment Program. So the QPP is the substitute for the SGR for those of us that live in the world of acronyms. And the QPP has two ways of adjusting physician fee schedule payments. And in our two prior webinars, we've really focused on the merit-based incentive payment system. So this is the final score assigned to a physician based on his or her performance across four components: quality, efficiency, advancing care information, which is meaningful use, and then clinical practice improvement activities. We find the score on those components, and we calculate a final score, a number between 1 and 100. And then depending where an individual physician's score compares to a national threshold, that will determine whether his or her fee schedule of payments are adjusted upward or adjusted downward. So that's the first model under the QPP for making adjustments based on value. And again, that's a pay-for-performance model straight up. The other half of the QPP program is this concept of advanced alternative payment models, because CMS says, well, Congress actually, I apologize, Congress said at some point you get so far removed from fee-for-service reimbursement that it doesn't make sense to simply adjust payments based on pay-for-performance, that there are certain payment models that are now emerging that we want to create a different set of incentives here for improving value in healthcare. And so we have this concept of advanced alternative payment models. And it's around these that we want to talk about the opportunities for physicians moving forward.
So Martie, as we think about the sequencing, MIPS is live and OCM is live. What do we anticipate in terms of sequencing? For those who are on the phone, is this the distant future, or is this next year? What's this expected evolution? Because it is supposed to be an evolution. Not all practices, initially practices are signing up to participate. They're doing it by choice. With the ACOs, there were the pioneer units. But at some point in time, the expectation from the policy leaders is that everyone has moved on to one of these new systems of reimbursement. What's that timeline look like?
It's interesting for nerds like me that read the 900 pages of the MIPS final rule. At the very back of that regulation, CMS, pursuant to the Paperwork Reduction Act, has to do projections on the financial impact of the regulation on the regulated. And in that discussion, CMS quantifies how many practitioners will be subject to MIPS versus how many will be under the Advanced APM component of the Quality Payment Program. And for 2017, CMS puts the number who will be impacted by MIPS at about 600,000, give or take 10 or 20,000. They estimate the numbers that will be in Advanced APMs about 60 to maybe 100,000. So clearly it is heavily weighted towards MIPS, and that only those providers who have got their toe in the water under Advanced APMs will be under this model initially. But as we talk through this, you're going to see that there are incentives built in to keep pushing providers from MIPS over to Advanced APMs. And the incentives are such that you eventually reach a decision point and say, it's time for us to pursue Advanced APMs because we're not getting where we want to be under MIPS. And CMS expects that as it builds this program out. So let's talk sort of about the logic here. And the beginning point is the key terms. What is this MACRA definition of an Advanced APM? Well, there are three key components. To be an Advanced APM, you have to involve the use of a certified electronic health record. That has to be a component of participation in the model. Secondly, you have to have quality measures. You have to have those regulators on performance that are built into the model. And finally, that model's got to involve some degree of risk to the participants, more than just a nominal financial risk. But in fact, there are dollars that otherwise would have been paid to the provider under fee-for-service that they will not receive if they do not perform to the standards within the model. The one alternative there that CMS offers, that's part of MACRA, are medical home models that require specific transformational activities on the part of primary care practices that if they are in an Advanced APM with those medical home model criteria, that's going to meet the definition of Advanced APM. Now, just because you're in an Advanced APM isn't enough. You then have to be either a qualifying participant or a partially qualifying participant. So this is sort of like meaningful use. It wasn't enough that you just went and bought an electronic health record. You had to demonstrate through attestation that you were in fact utilizing that EHR in a meaningful manner in your practice. Same here. You can't just sign up for an Advanced APM. You actually have to have a certain number of dollars or a certain number of patients that are impacted by your participation in that APM. If you meet the standard for a qualifying participant, you're not subject to MIPS, and you're automatically going to receive a 5% bonus payment on all of your Medicare physician fee schedule payments. Then there's this concept of a partial qualifying participant. They are lower thresholds. So lower total dollars, lower number of patients. They're just not subject to MIPS. They don't receive the bonus payment. So that's the two categories CMS has set up under these Advanced APMs. So what qualifies as an Advanced APM? MACRA directs CMS to publish a list every year of what's qualifies in the Advanced APM. So it's not a matter of you applying the criteria I just referenced. It's how CMS applies that criteria I just referenced. And for the first 2 years of QPP, 2017 and 2018, they are exclusively traditional Medicare programs. So Medicare Advantage, commercial insurance, Medicaid, none of that goes into consideration for whether you're part of an Advanced APM. It has to be one of the traditional Medicare APMs. So that starts out in 2017 with tracks 2 and 3 of the Medicare Shared Savings Programs. Those are tracks that involve risk. The next generation ACO model, the comprehensive ESRD care model, comprehensive primary care plus, which we discussed, which actually goes in as a medical home model as opposed to a risk-bearing model. It is a sunsetted participation there. And finally, we have the oncology care model, but notice it has to be a provider that a practice that's in the two-sided risk model. And even though OCM called for that transition not to occur earlier than 2018, practices will have an opportunity to elect two-sided in 2017 so that they can be qualifier for an Advanced APM. In 2018, we have several more programs that CMS promises to bring online as Advanced APMs, including this new concept of a Track 1 Plus ACO, as well as those episodic payment models we discussed earlier. Here just briefly, and we won't go into any detail here, under the first 2 years of QPP, when it's only traditional Medicare, here you see the qualifying thresholds to be either a qualifying participant or a partial qualifying participant. And you see that those go up every year. So if you want to keep your status in an Advanced APM, you're going to have to continue to bring more dollars and more patients into consideration. Now starting in 2019, we can have other payer advanced APMs that will qualify under the QPP. So here's where programs under Medicare Advantage, Medicaid, commercial payers can begin qualifying as an Advanced APM and be considered going forward. However, you have to get prior approval from CMS to qualify as an Advanced APM. And again, you see here the criteria that CMS has to apply. So if you work backwards, that if it's in 2019, these would be online. That means CMS is approving them in 2018, which means it's right now in 2017 that you have these payers looking at how to design these programs. So there is conversation in all of these markets right now about how do we create these Advanced APMs, meaning there's going to be more opportunities for providers to work their way into these programs. And again, here more percentages. This talks about how you would qualify under other payers to be a qualifying participant. Appreciate here that to accomplish this, you can't only be in an other payer advanced payment model. You still have to be part of one of the traditional Medicare programs as well.
Martie, let's take a question from one of our listeners. Are you allowed to participate in an APM if you have applied for hardship for meaningful use? And in answering,
yes, you are.
Explain.
Sure. Yes,
so
you are, because I'm sorry?
So explain it if you could. What is the hardship for meaningful use for those who aren't familiar?
Sure. Meaningful use now is a penalty, not a bonus. And what the Meaningful Use Program has allowed over the last several years is that if you are in a region, for example, where there's not reliable internet access, that is a basis for applying for a hardship exception. So you don't have to attest to meaningful use. You instead say, I have a particular defined hardship that prevents me from meeting all the standards for meaningful use. Now remember, meaningful use goes away. And instead we have this concept of advancing care information as part of the MIPS score. So the MU program for physicians is gone. It has sunsetted after 2016. The requirement to be an Advanced APM, you have to include use of a certified electronic health record. That is the model itself. The model itself has to have that requirement. The model can build in its own hardship exception for its participants. Of course, that's going to be tested against criteria similar to what CMS has used for hardship exceptions. But this is not intended to preclude participations of providers who are willing to otherwise accept the parameters of an APM.
All right, so I would say with our 10 minutes remaining, let's go ahead and see if we can knock out the last segment on MIPS APM scoring standards.
Okay, and this should go pretty quickly, but as you recall, there's advanced APMs, but then there are other types of APMs, and probably the one most common is folks that are living in the Medicare Shared Savings Program in a Track 1 model. They are still reporting on quality measures. There are the specified quality measures on which an MSSP ACO has to report to CMS to qualify for any shared savings. One of those measures involves a percentage of participants who are using a certified electronic health record. So CMS wanted to have some method by recognizing participation in these MIPS APMs. So we have two concepts here. As is often the case in these regulations, we have advanced APMs, which meet those three criteria approved by CMS, but then we have MIPS APMs. And for our purposes in 27, that's going to include all those advanced APMs we already talked about, regardless of whether you're a QP or a partial QP. But it's also going to include MSSP Track 1, and it includes OCM one-sided risk model. So for participants in these programs, rather than the traditional method of calculating the MIPS score, 4 components, reporting information, all those details, these participants instead are scored under what's called the APM scoring standard. And it's pretty straightforward how it works. Once I click the right button, sorry about that, it is going to apply to all of those MPIs, all those physicians and non-physician practitioners who are listed as participants in a MIPS APM as of December 31st of the performance year. Okay? And all MPIs who are part of that particular APM are going to end up with the same final score. That's going to be the MIPS APM score. So if you are part of an MSSP Track 1 ACO, you do not get to elect to report individually on MIPS or report as part of your group practice. Your score will be assigned based on the MIPS APM score. So how this works then is CMS will calculate the score for the APM, so for that oncology care model practice or for that MSSP ACO, on a criteria that divides out 50% quality, 20% clinical practice improvement activities, and 30% advancing care information. Now on the quality component score, CMS is going to convert the APM's score on the required quality measures into a MIPS quality score. So for an MSSP ACO, it's the ACO score on all those required measures. For an oncology care model one-sided practice, it's going to be the practice's score on those measures that will be converted into the quality score. That's half of it. Then for clinical practice improvement activity, you get full credit automatically if you're in any of the MIPS APMs. So you don't have to worry about any other types of activities as long as you're part of that MIPS APM. Finally, you've got 30% on advancing care information, and this is the one place where individual reporting still comes into play. Because if you are part of a MIPS APM, you are still going to have to report to CMS on advancing care information. So if you remember back to the prior webinar when we walked through the base score and then the performance score and the potential for bonus points, that will still come into play. CMS recognizes that you could have participants in an APM that are not using a certified electronic health record. It just means that that participant's score, as it contributes to the APM's overall score, will be 0. So if you have an MSSP ACO, you have 10 different participants. If 2 of those participants do not use a certified electronic health record, they'll be zeros, and that will simply bring down the APM score. Reason for that? CMS wants to incentivize ACOs and other providers and APMs to require participants to use electronic health records because otherwise it negatively impacts their score. So as you're choosing partners to be part of an APM network, what you want to consider in part is how are they going to potentially impact that score as well. So that is how that will be applied going forward, this is the reason we're predicting that there's going to be a significant uptick in applications for the Medicare Shared Savings Program. Even though Track 1 doesn't get you to Advanced APM status, it gets you within this scoring mechanism. And so you are not having to double dip on reporting requirements, and also have the advantage of your participants help raise your overall final score. So there, we'll close that up there, and we've got 5 minutes left, Bruce, for some questions.
Thanks, Martie. So for practices that you consult with, how are you seeing them approach what seems like almost an overwhelming amount of information and process? Are they selecting an administrator who is going to be their internal czar, whose task it is to understand all this cold? Are they using consultants to manage them through it? How are they bringing the doctors in? In my conversations with doctors, the most common response I hear from a doc is they don't really know anything about it, but somebody in the practice is taking care of it. And will that be a long-term successful strategy?
Yeah, that was a great strategy under PQRS, and even meaningful use, is that you really did have the practice czar who had mastered these programs or had resources on which he or she could call to help them with compliance. And it's because those were really passive programs. I mean, PQRS is you provide the care and then you go back and you measure performance. That's just not the case under the quality payment program. It is really driving into how you perform. And remember, our last webinar we talked about scores on quality measures and how critical it was to engage in performance improvement activities within the practice so that you could raise the overall score on selected measures. And certainly with APMs, participation in APMs cannot be passive, because you have to be, as a team, tearing apart your current practices to identify where is there inefficiencies, where can we streamline process. And so yes, it's still important to have one person in the practice who really takes charge, but all the physicians in the practice need to have a basic comprehension of how these programs are working. Because again, think about what we talked about at the beginning. You're completely changing the incentive structure. And if you've been operating under an incentive structure that's encouraged by fee-for-service, where it's more patients, more services, that looks completely different when you're being paid for value. And so there has to be, within the evolution to new payment models, an evolution in practice as well.
So Martie, that was great. A lot of material covered today. I want to thank everyone who called in, certainly those who called in for all three. And I guess before I close out, I've got one final question. What data would you use to decide whether to participate in APM or in MIPS? So Martie, that was for you.
That's a hard one because everyone actually really needs, if you are in an APM, right? So if you in the Medicare Shared Savings Program, if you're in the Oncology Care model, you're going to be scored under that APM scoring standard. So you're going to go through the process of working through those quality measures. So you've selected the APM side of the house. If you're not in one of those programs, you're under MIPS, and you're going to move forward with reporting as we've discussed previously. The decision on whether to get into an APM is really one that is about what the practice wants to accomplish and how they want to position themselves in the market, where they want to align with other independent practitioners, or how they want to align with health systems in their communities, because the Advanced APM is promoting that. If you're part of an ACO, you are part of the process that ACO has built to make decisions on right care, right place, right time. And so it's not necessarily just a pure numbers consideration. It really is where do we want to fit in this market? Where do we see opportunity so that we have access to lives? Remember, that's the difference now. It's access to lives for which you provide population health versus individuals for whom you provide services. And that's the big consideration. Those are big thoughts practices need to be having at this time.
Marty, that was great. Thank you. There'll be a couple closing comments by Keith, and who knows, maybe we'll be back in touch with you all on a different topic in the weeks and months to come. For the additional questions, we've run out of time, but we will take note and we will try to respond online. Thanks, everybody. And Keith, final closing comments.
Thanks, Bruce. Thanks, Marty, so much for your insights today. Just a couple final notes. Tomorrow you'll be receiving a thank you email, which includes a survey, so please take the survey and let us know your thoughts on this webinar, what other kinds of topics you'd like to cover as well. Also, we have a MACRA helpline available to webinar participants for 2 weeks after the meeting. Some of the questions may be able to be answered through there. You can email Marty at mross@pyapc.com. And our Cardinal Health Specialty Solutions team is also available to answer questions. That email is cardinalhealthmacra@cardinalhealth.com. You'll also receive a recording of today's webinar. That should be coming out next week. And also, don't forget that we have previous webinar recordings and some more articles with in-depth coverage of MACRA on our MACRA Resource Center, which is cardinalhealth.com/MACRA. Thanks so much for everyone for participating today, and best of luck to your practices.